About a year ago, I published a paper actually on early identification of patients with chronic pain. And I think it's really important to do that. Otherwise, what typically happens is patients who ultimately will be identified as having chronic pain will go through treatment as usual, and it can go on for years with no results, except that time has now passed. The more time that passes, the poorer the prognosis becomes. So that if I land up seeing the person in 4 to 5 years from the point at where these problems began, the outcome from what I can do is dramatically reduced. Often patients are sent to me after 4 or 5 years of a problem, and there's an expectation from the referring source that these people are going to miraculously go back to work. The literature is very clear. If a person's been away from work for a year, the likelihood of returning to work is about 10%. If they've been away from work for 2 years, the likelihood of returning to work is almost 0. So it's just an unreasonable expectation. The earlier that patients with these problems can be identified, the better the outcome becomes for them. And what I've done with some physicians now is I've tried to teach them those skills in early identification. And that's what I bring to the table. Is the assessment is the sooner I see them, the better. And there are very specific things that I look for that can identify patients at risk and then design an appropriate treatment plan. I'd like to say that there's a 2-year waiting list because I'm that good. But I don't think that's actually the reason why. I think the reason why is because the problem of chronic pain affects about 30% of the population. And in this region, there's only 2 clinicians who do what I do. One of them is me. And I think the reason for that at this point is that chronic pain as a specialty area is really not very sexy. It's a lot of work. It takes a long time with each person. It's rehab. It's not acute care medicine, so it's a little bit different. And at least at this point in time, there aren't any new residents being trained in this field. And hopefully over time, some people will get more interested. In order to stimulate that, I've been meeting with some of the heads of departments at the university. And actually from that, I just got a contact from a resident, the first time in my career, a resident from my area of study, which is psychiatry, who would like to come and do some training with me. So it may be the beginning of something. I mean, psychologists and psychiatrists do share skills. In the world of chronic pain, my colleagues in psychology, I think, do a very good job of treating patients with mood disorder and anxiety disorder. Their skills are focused on non-pharmacologic management strategies. On my side of things, and what I bring to the table, I mean, I'm trained as a physician first, and part of my skills include pharmacologic management of a given problem. And my focus of non-pharmacologic care is the management of chronic pain specifically. In order to do that, you need a multidisciplinary pain program. It is not done as effectively in individual treatment. It's been well demonstrated in the medical literature. The reason for that is because multidisciplinary pain programs have functional components attached to the psychological components. It's happening at the same time. As you can appreciate, a person with chronic pain talking about the problem does not get them activated. You need to get people physically activated so that they can deal with the problems of being more physically activated. And that's what happens in a multidisciplinary pain program. Our program is identified as meeting the standards of the International Association for the Study of Pain's criteria for a multidisciplinary pain program. They have very specific criteria. And those criteria, in summary, are that it has to have, the program has to have a wide diversity of professional staff. In our program, we have occupational therapy, physiotherapy, nurse, social work, nutritionist. We have a specialized martial artist who teaches Tai Chi. We have aquatherapists. As well, the program has to have an overarching method of practice, specifically cognitive behavioral. And all of the staff, in the program. All of the direct clinical staff are extremely well trained in that area in my program. And the vast majority of my staff have over 20 years of experience, specifically in the management of patients with chronic non-cancer pain.